Muy buenos días. Lo primero es agradecimiento al conferencista y a ustedes por estar aquí. El ingeniero Tomás Yud es Magister en Science, está ahora trabajando con el National Project, es el director del proyecto de Káiser Permanente de Tecnología Clínica. El de Tomás Yud es miembro fundador del Colegio Americano de Ingeniería Clínica, con una carrera de 36 años y es certificado en Ingeniería Clínica. Desde el año 2006 es el director del National Project, el Proyecto Nacional de Tecnología de Káiser Permanente, y es el líder de la integración en la parte de dispositivos médicos de Káiser Permanente. Realiza la evaluación de tecnología en salud en un centro que llama Centro de Innovación de Káiser Permanente en Gradfield, y es fue director de calidad y seguridad de Káiser Permanente en Georgia y es consultor de la Organización Mundial de la Salud. La conferencia va a ser en inglés, pero él dijo que he's going to speak slowly para que ustedes puedan entender y todos podamos entender. Muchas gracias, bienvenido, doctor.
Buenos dias. Of course, that may be my last Spanish. Come on. I think I'm going to make it. They're seeing all my other presentations for the day. Finding the cursor. I'm just trying to find the cursor. There we go. There we go. There we go. Perfect. All right. And next slide. Okay. Very good. Well, it's a great joy to be here. And thank you, Dean, for the introduction. Now, shall I tell you a lot of stories about Tatiana? No, as the answer apparently she's giving me. But you recognize that our professional society, which turns 25 this year, and it started in North America, but it's a global clinical engineering professional society, awarded CES and Tatiana an international award a couple years ago, so you should be very proud of her. Káiser Permanente, perhaps you recognize, provides the care in the United States for about 9.5 million Americans. So we are struggling with our health system model, like you are in Colombia to some degree. But people say perhaps Káiser is the right model. You can see some of the things we're up to today, and you can decide. So, yeah. And I've been around the field, was an aerospace engineer, but became a medical engineer, and I think as a person that was trained to be a warrior, I think it's harder to heal. It's more of a challenge to heal, so I applaud the profession that you're in. that I've also been in for 40 years. A little bit about the presentation today. What is the world in which we need to put technology to help healthcare? And I think we're all pretty understanding of that world. So I'm going to talk a little bit about the context of healthcare in my country and a little bit about yours. I'm certainly not an expert in yours. The medical device industry, how does quality fit into that? It's very important, we know that, but how does it fit in? And I don't think we can talk about technology in healthcare today without talking about electronic health records, without talking about what I call and what you call health IT. So more to say on that. So what about my organization? How are we using medical devices and health information technology, health IT, in creative ways? And I would say we're among the leaders in the U.S. Certainly, we have something like 40 hospitals, 600 clinics. I'll say more about that. The Veterans Administration in the U.S. has 150 hospitals. So we're not the biggest, but perhaps the biggest private system. So how do we define quality, and then how does health IT and medical device work fit into that? And then I want to get into some case studies that demonstrate what I'm discussing. Okay, when I talk about quality, and I talk about the context of healthcare, I think some of you are familiar with what they call the Affordable Care Act, ACA. Many people like to call it Obamacare. You've heard that. But what is it that's going on in Obamacare that's important? I mean, there's lots of things that are important. We had, 20, 30% of our country that weren't insured to get their health care, and Obamacare is trying to address that, but I'm not here to talk politics. But the notion, I think there's a law in Colombia that's fairly new, 2011, that said there should be an electronic health record for everybody. And maybe, I believe that law was enacted and completed at the end of 2013, but it's not yet fully implemented in 2014. There was a similar process, an earlier president in the United States said every health system, every person will have an electronic health record by about 2014. Well, that's now. How did they propose to get there? And the answer is, the incentive of money. They said, we will reimburse physicians, we will reimburse hospitals if they get an electronic health record to serve their patients and they use it in wise ways. If we flash, that was several years ago, it was President Bush at the time. If you fast forward to 2014, there was a study in July of 2014. You know science, there's always conflicting studies on one side and on the other, but one of the most recent definitive studies said health IT is improving quality of care in heart failure, pneumonia, sepsis, and stroke. In my background, 40 years as a biomedical engineer, as a clinical engineer, I spent 12 years as a quality director, sort of unrelated to medical devices per se. In that time as a quality director of a health system, I know that heart failure, congestive heart failure, is the biggest reason people get admitted to the hospital in my country. Perhaps that's true in Colombia. So it's a pretty big deal, heart failure. Pneumonia, I think the clinical people in the room recognize that pneumonia is the reason most people get discharged from the hospital, unfortunately dead. Pneumonia is the killer, the biggest killer in hospitals. So if health IT is affecting these two critical health conditions in smart ways, that's important. And of course, we start to talk about sepsis, you know, the infections that everybody knows that often you go into the hospital and you get sicker in the hospital than you were when you went in. And often sepsis and the infection related to that is a contributor, so that's a big deal. And then stroke, of course, for us people, young people like me, just kidding, that are getting older, stroke's a pretty big deal. So, and as I said, what's going on in Colombia? You know, the law that you're very familiar with, that one of the health leaders, my friend from Barranquilla, said it's just not implemented yet, but we're heading in that direction. So then we say, well, okay, if we're starting to talk about quality in healthcare, quality costs money. It costs an investment. Is it worth it? What's the business case? So we'll talk about that. What are some more of the challenges that we want medical devices and health IT and improved quality to address? Chronic disease management. I think everybody knows the laundry list of what's chronic disease management. Hypertension, high blood pressure is a pretty big deal in Colombia, from my readings. For reasons that maybe somebody in the crowd can tell me, and I don't know, is diabetes is an issue, but not so big an issue in Colombia. Maybe it's all the fresh air and all the walking you have to do, I don't know, the diet. But you know, depression, asthma, several other chronic diseases. Heart failure is a chronic disease, COPD. Anyway, you guys know what chronic diseases are. Chronic diseases are eating up the budget for healthcare in the U.S., both on the public side and the private side. So how do we devise the care protocols around chronic disease to make a difference? And I know Colombia deals with these same issues as well. And so can technology, and I'm thinking very sort of at a high level, can technology address chronic disease management? I think the answer is definitely yes. None other than our friends at Google are doing some studies right now with some of our leading universities. Can you find those biomarkers that tell you that you're going to have a chronic disease? Can you do point-of-care testing, maybe in the general population, screening in some ways, genetic testing, to find and address this earlier? Now, I have to tell you a small aside. Where will I, in my city, I live in Atlanta, Georgia, where will I get a lot of my health care in the next 20 years? Certainly I'll go to the clinic that's down the street, but I'll probably go to the drugstore. I'll probably go to CVS and Walmart and, you know, so I think you understand me. It's because more and more care is being delivered out of drugstores, and the important thing is we need to get care, particularly for chronic disease, where we live. And if we've got a clinic, you know, 5 kilometers from our house, and we've got a drugstore, they may be able to not only see how well we're taking the drugs for our heart failure or our hypertension, but they may be able to feed that back to the health system, and we can do more preventive work. So that's a small aside. But the prevalence of chronic disease management in my country, and I suspect in yours, is growing. All right, let's talk about medical devices. Wow, there's so many wonderful things that can be done through medical device technology. We all agree to that, I think. The problem is those devices have become more complex, and they've become trickier to manage. One example that I'll talk more about is infusion devices. Wow, infusion devices, infusion pumps, syringe pumps, PCA pumps, very important to care, cancer care, all kinds of care. And you can build into those systems how accurate they are. You can actually integrate those systems in with an electronic health record. It's not happening very much yet, but it's going to. where there can be closed-loop control. In other words, based on my blood pressure right now, the infusion pump, based on some algorithm, will change automatically to maintain my blood pressure. Those kinds of things are coming. But what this slide is trying to talk about, in our regulatory system, our Food and Drug Administration, that people report the problems with the devices in the patients. The adverse events, bad things happening as a use of care being delivered with technology, is going sharply upwards at the same time the number of devices able to treat. And it's because of a variety of complexity reasons that we'll talk about. But there's a cost, there's a management needed for all these devices. So back again, though, okay, Tom, that sounds good, but how are we going to pay for this? How are these medical device industry going to make money selling devices that help the population improve their care? From the consumer side, Káiser Permanente is what they call an integrated healthcare delivery system. What does that mean? That means we have the hospitals, we have the clinics, the doctors in some ways work for us, we have all the other allied health, the dialysis center, the infusion center, all of these are part of our system. So if you go into the health system, there's one-stop shopping. All of your needs can be met. But so from our side, what does quality mean? And for us it means, does it work right? Does it last a long time? And is it easy to use? That's what we think about. Well, industry thinks a different way. Down the street this afternoon, I'll talk about medical device industry and the whole use of quality systems, which I think those of you that know industry know that's the framework in which devices get built, quality systems on the industry side. But, everybody's got to win. The device has got to be profitable, but it's got to be safe. And how do we work with that? And just at a time when, technology is improving health in so many ways, there's a lot of extenuating factors that change. There's this whole issue that I think some of you are familiar with, interoperability. How does all the information that's created by devices and other kinds of information in the electronic health record, how does it fit? In other words, let's think about a patient monitor that's creating vital signs. And those vital signs, that's a lot of information coming off of one patient monitor in an intensive care unit for one patient. Does that go right into the electronic health record, straight data? No, of course not. It's got to go through some middle step. And then it's got to be trended. Maybe there's some nurses in the room. You have a flow sheet, and it, every 15 minutes, every hour, it's got the vital signs collected. How does that data, that continuous flow of patient monitoring information, maybe of 5 variables, heart rate, blood pressure, respiratory rate, how does that get filtered and put into the flow sheet so the nurses and doctors can track your care in the electronic health record? All of that relates to interoperability, big word. Then we know, well, if we want devices to be wireless. I've got time, so I can tell a few stories. Doctors in the room know that electrocardiograms, ECG, EKG, has always been a big deal. I mean, it's a accurate technology. I could tell a funny story on my wife, but I won't. But she had chest pain. She came into the clinic with chest pain. She's a healthy person. And they turned out to be reflux. And it wouldn't, but to rule out chest, heart issues when she came in for chest pain, they had to do an electrocardiogram. Well, We all know what happens. The doctor writes an order. This is in a manual world that we've lived in. The technician comes in with a machine. They take the EKG. A paper strip, is taken, and then it goes to a doctor who reads it, and then maybe it goes to another cardiologist who overreads it. Okay, let me tell you about electrocardiogram in the integrated, interoperable world. So now the doctor makes an order into the electronic health record. It instantaneously goes to the EKG technician who goes to the bedside. The EKG is taken and it's wirelessly transmitted back to the electronic health record in some fashion. So now the EMR, electronic medical record, electronic health record, knows that there's an EKG to be read. Well, it sends a signal, an email, an in-basket of the doctor that's going to read it. He reads it, makes a discussion decision. Maybe he has some extra algorithms to help him analyze and calculate the EKG. But he does his read. He emails back to the EHR, I've read this, but we know in most systems, so we're not talking about doctors carrying EKGs home at night to read anymore, which is a pretty big deal, and they get lost. Or the primary care doctor is supposed to read them, and they're very behind because they have so many other patients. No, we're talking about the EHR-driven EKG. So the first doctor has read it quickly with some tools to help him or her read it fast, and then they send it back, and it goes to the second doctor to overread it and to say, yes, the first doctor got the diagnosis right. And then it comes back to the EHR, and it comes back to the referring physician and here's the answer. All of that takes place in less than an hour. For those of you or doctors that have had to read EKGs, you know that's way faster and way more efficient than what's happened in the past. So wireless is just one component that enables that very fast transaction that's better quality care. We all know about mobile health. I can start taking my EKG with the right sensors and tools on my smartphone and send it in wirelessly to be read. We all know about that. Security. I think you can open the paper every day and see this bank has been hacked. Target, Walmart has been hacked. This is patient data. How are you going to take care of it? The story, I guess it's not too funny based on your politics. The vice president of the US a few years back has a pacemaker. Somebody could hack into his pacemaker and change that. So I think it's enough to know that security and privacy are big issues. And then human factors. If we're pushing care out from the hospital to the home, and we're talking about your mom and dad, do they know how to use what it is that they're supposed to be using? So I think you get my point. So these are things that complicate the challenge that medical device industry has. All right, so a quick story, true story. Quality costs money. For a medical device manufacturer, for example, how do they make money when they have to spend money for quality? And in this story, my organization, you heard, has a lot of practitioners and a lot of patients. We were using Baxter infusion pumps. For about 4 years, the country said, come on, Baxter, you can do this right. Come on, we know you can fix this. And they finally said, nope, time has run out. After 4 or 5 years, you've had so many problems in your design that there's a recall and all of the devices have to be sent back. In my organization, that was a big deal. I don't know how many exactly we had before. We turned in all the ones we had. I actually led the project of getting finding them all, the rentals, the ones hiding in the closets, all of them. We got $31 million of reimbursement just sending in old Baxter pumps that had been recalled. We deployed 17,000 across our 40 hospitals and 600 clinics. So a pretty big deal. So when in this complex world that I was describing for the manufacturers and the providers of healthcare, the Food and Drug Administration, the regulatory system in my country around devices said, you've got to build in these kinds of issues, design and reliability, monitoring and feedback. You know, the original manufacturer, Baxter, probably didn't make all of the tubing and all the accessories, so you've got to work with your subcontractors, your suppliers. You've got to build in quality metrics and systems. You know, this is a bunch of words. If I kept going with those words, you know, we'd all be asleep. But let me see those words come alive a little bit. So there was a company in Europe that had trouble with quality cost. What am I talking about? When you put the product out there and it's during warranty, and then there's a lot of problems during warranty, that's quality cost. You didn't put out a good product in the first place. Oops. Having fun with this here. I'll get back someday. No. Going the wrong direction. We'll get there. Anyway, they weren't preventing the problems before they happened. They were not having good supplier performance. So they said, we're going to invest in quality to see if it makes a difference. They started reducing those. They got it right the first time, and they ramped up how many they were making. So they made more of them, and they made them better. They reorganized the quality function. They put in this system for tracking and talking about, you know, incremental improvement and root cause of what the problem is. For example, we now have, you know, and I'm not trying to sell you, I don't own any stock in any medical device companies. We bought CareFusion's Alaris pump. That's the one we have 17,000 pumps. And many of you know that on these high volume infusion pumps, you hang modules for specific purposes. You know, in an intensive care, you might have 3 different IV lines going at the same time. So there might be 3 modules hanging off the pump. We've got 27,000 modules. So anyway, what we were finding is in some of the infusions, the way the tubing fit into the infusion pump, there's problems. There were over infusions, and you know, the clinical people in the room know that's a big deal. That kills people when you over infuse the wrong thing. So when we gave that feedback to the manufacturer, how did they, you know, is it an education problem? Do the clinicians need more education? Or is it a design problem? That's the kind of dialogue I'm talking about that needs to take place. Well, basically, this company addressed all of these issues. They reduced the cost of quality, in other words, less warranty issues, less claims against their device by 35%. They actually improved revenue by 2.5%. For the business people in the room, 2.5% on a big number is a big number. So FDA said, do these things. This company did those things. It improved a lot. And actually in 2014, this particular foundation in the US went to FDA and said, okay, thanks for your feedback a couple years ago. Here's what you want you to do now. We want you to get products to the market faster. Help us get products to the market faster. Help us, you know, do surveillance on how well they're doing. Here's something Tatiana and her engineering friends know about. There's a unique device identifier. How many in the room have had a hip replacement? I'm a young guy, 64 going on 44. But I had a hip replacement 4 years ago. You all know that there's been a huge problem with manufacturers of hip replacement bionics. Fortunately, not mine. But how do you know what hip was put in what person and which ones you know to do about it, that's tracking. That's unique device identifier tracking. And then what if you have clinical registries? What if you know all the people that got a certain treatment and you can go back and do research on that and you can track them better? So these are the kinds of things that improve quality. So McKinsey did this business case and found that investing in quality is a very smart thing. It not only improves care delivery to patients, but it improves your bottom line, your profitability. All right, so I'm going to switch and say, okay, in the midst of all this complexity, all this interoperability, the wireless, the mobile health, and all of that stuff, we better do something to improve health IT. In other words, is the electronic health record going to improve care or not improve care? Okay, there's this small thing that happened last week in Texas with the Ebola patient. And first they said it was the electronic health record's fault that they didn't catch that patient when he first came in from Western Africa. Because they said the nurses that checked the patient in at the emergency department didn't have a system within the EHR that connected to the doctor's information. But they later said, nope, that's not true. It's not the electronic health record's fault. It's the processes within the hospital that didn't speak to each other. So it's a pretty big deal to integrate an electronic health record and health IT tools into your care delivery processes. It's a very big deal. So this was coming about, though, in if you have very good eyes, April 2014, the Food and Drug Administration's Safety and Information, anyway, we now, because President Obama about 5 years ago said, we're going to use health IT to improve health care in the US for our population, and he's put about $30 billion US into that. That's where all this reimbursement in hospitals and individual doctors. And that's why individual doctors and small doctor groups started to get computers that had electronic health records so they could line up to get the reimbursement that the government would offer. By the way, there was about 5 years of get the EHR, submit the information, get the bonus. But guess what happens at the end of 5 years? They start to be penalized. So there's great incentive to do that. What I'm telling you is that our regulatory system has begun to act on how do you analyze risk? How do you analyze how medical devices contribute to that risk? Then you may ask yourself, okay, Tom, I know intensive care units and I know in surgery, there's lots of medical devices. I get that. But tell me again, how do medical devices contribute to better electronic health records, which we showed earlier contributes to improved care of trauma, of chronic disease, of mothers and babies? How does it help? And actually, time permitting, there's a dozen different ways that medical devices fit into electronic health record workflows. And I'll come back and talk about that a little later, but just really in every aspect of care delivery. Knowing who the patient is in the first place, getting them in there in a timely way, getting their care scheduled and delivered and followed up. All of that is sort of in an electronic, is medical device driven. So like I say, each of these workflow device, more information is found in the appendix, which I'll be sharing with you. How are we doing on time? Okay. Let me know. All right, so I've said a few things about Káiser Permanente. You can read here, it's been around, 15, 70 years, integrated, lots of doctors, lots of nurses, lots of employees, different parts of the US, East and West. I will tell you that About 7 million are in California, where we've been the longest. Hospitals, clinics, a fair amount of money being generated. How do we measure quality? Remember, yes, I'm an engineer, but I was a quality director for the part of Káiser over in Georgia, in Atlanta. Go Olympics. Yeah. But there's lots of ways we measure quality. Maybe you've heard of the Leapfrog group, which is about processes that improve patient safety. In other words, somebody comes in with a heart attack. There's about 6 different things to do for that patient right away. Do you do all of them? And they will survive. That's the Patient Safety Award. There's awards about our website. There's awards about our electronic health record being fully developed. About it, Kaiser's a good place to work. We're very wired. We've got our wireless capability very widely deployed. We're one of the best group of hospitals. This is, our Medicare and Medicaid patients. You don't want me to explain all this. But, we gotten certain patient safety awards. And then this last one here, the Davies Award, in the HIMSS, some of you recognize Health Information Management. Anyway, it's a big professional society. Now, Tatiana and I go to these, sometimes go to these conferences around medical devices and industry, and there's 2,000 people there. Well, when you go to the HIMSS conference, HIMSS, there's 40,000 doctors, nurses, industry. It's because of that $30 billion investment in health IT in the US, it's a very big deal. But the HIMSS Davies Award says, okay, you've deployed electronic health record, your doctors are using it, electronic health record, what are the main things Tom, tell me 3 things about electronic health records. One is there's computerized physician order entry. So around every kind of condition that you're going to treat, doctors, not IT people, doctors have worked out what are the best protocols to treat that disease, and they've embedded all that information into a computerized physician order. So when the doctor says, oh, they've got heart failure and it's this far along, they can click into the electronic health record and say, oh, here's the order set on how to treat it. What drugs, what dosage, what timing, what other aspects of care. So CPOE, computerized physician order entry. Another thing is if you have all this data that you're collecting around patients, can you use it to predict what may happen? And that's clinical decision support, CDS. So do you have CPOE, evidence-based order entry? Do you have clinical decision support tools like to predict when a patient is on their way to getting sepsis but doesn't have it yet? They've got the markers, the pre-indicators for sepsis. And then you have to deploy all these tools besides CPOE, CDS, clinical decision support, and get a return on investment. It's got to make good business sense. Doing better care has got to pay off. So more to come on that. All right, kind of a hard slide to read, but for those of you that know the buzzwords, we hit all the buzzwords in Káiser. And what this is saying in the previous 10 years, if we were paper-based, we're going to all electronic-based. We've got, our electronic health record covering all the clinical areas. Then we put a website online so that, somebody could help you with your own personalized healthcare plan, that you could make electronic visits and appointments, you could get drugs refilled, you could get labs reviewed, all of that online, so you have very quick access to your information. Then we have different analytics tools. One of them is called Archimedes, but different tools to analyze all this data and then predict. We have to do that in a world that's very regulatory involved. We have to embed all of the different business and clinical tools, lab information system, radiology information system, pharmacy information system, all those tools have to be embedded in this overall record. But now, you know, communication tools, of course, everybody's got a contact center. Who do you call when you get sick? You call the nurse, you call the appointment line. But more and more of this is happening wirelessly and, you know, voice control, maybe voice over the internet. But now we're moving into this world of digital health so that you can get care wherever you want it, wherever you need it. And by the way, this presentation and its appendix is going to be available electronically to download. So social media, oops, almost did it right. No. I can pick up the pace here a little bit too. So where are we going with that? What are our priorities? Delighting our customers, real-time, personalized care. That's where we're heading. All right, even though this is kind of a boring slide, it actually is the most important slide. This is how Káiser uses technology to improve care in words. Fortunately, I have some cool pictures to follow. We're meeting the meaningful use requirements. I'm going to show you that in a minute, but that means having an electronic health record platform and then doing smarter and smarter and smarter things with it. And getting reimbursed by the government for doing that. Here's that CPOE I was talking about, computerized physician order entry. Another thing that many of you know happens with electronic health records is that, okay, I've got a patient, I'm about to deliver a medication to them, and maybe they're on 2 or 3 medications, but then as you put in the order for that medication, the computer comes back and says, no, don't do that one. There's a drug interaction based on another drug they're taking. So those alerts and those what we call best practice alerts pop up and advise the doctor and adjust the trajectory of care as you're doing it. Social media driving patient engagement. Kind of the coolest thing I've heard about social engagement is, okay, somebody's coming in for a visit with their doctor. Let's say it's not an elective procedure in the hospital, or maybe it could be, or they're just going to see their primary care doctor in a clinic. What if the doctor's team started talking to them before they came with social media? And tell us ahead what your issues are. Maybe that would change the content of the visit to the doctor. And then during the giving feedback to the team, maybe with your iPhone, you know, when you're sitting in the office waiting for the doctor to come in, you know, engaging them then. And then after the visit, what if social media is used in your medical life the same way it's used in your personal life? How could that improve care? That's the kind of things we're thinking about, to be the patient more engaged with their health care. Interactive patient care at the point of care. I'm going to show more about that. Data mining for these clinical decision support tools. I'll show you more on that. Medical device integration in hospitals and clinics. More on that. I mentioned that diabetes in Colombia is a little bit less of an issue than it is in my country. Hypertension, high blood pressure, is a big deal. What if you were sending information to and from your doctor's team through the day, through the week about, you know, what you were eating and what your weight was and what your blood pressure was? Would that help your hypertension? I think so, if it was smartly done. What about wireless infrastructure and real-time location systems? If you knew where the patient was, you knew where the clinician was, you knew where the device was, you knew where the supplies were, all of this was sort of connected wirelessly, that could drive better, quicker, faster care. We're not doing too much of this yet, but you know that's the next coming wave in healthcare is to get genomic evaluations. A genomic evaluation in my country is down to $1,000 a person. That's still expensive. I wouldn't do it tomorrow, but it's getting so that you can find out what's going to happen to you before it happens to you. or what drugs and what dosage of those drugs are going to be ideal for you. And then telehealth, many smart things around that. More to come here. Maybe I'll pick up the pace a little bit. So here's the meaningful use requirements, the government requirements in the U.S. And you can see initially it was get an EHR and start using it. Then it was more about care coordination. I don't know if you've had a sick relative, if you've been sick. The problem is, who knows as you get handed off from one doctor to the next, who knows what's going on with you? How do you coordinate that care? It's a big deal. And then we're in the midst in the U.S. of being between stage 2 and 3, but more and more data, more and more patient self-management, probably with those smartphones I was talking about, more use of registries to know what because of that, and then eventually improve population health. So this is a direction we're heading in the U.S. on our EHRs. All right. I'm going to show you sort of some fun slides for a moment, but then get into our case studies, get into our data of what we're specifically doing. So what does evidence-based personalized care look like? It means we interact with them in interesting ways in the hospital and their schedule. For the clinicians, now they don't have to waste time writing things down because it's automatically put into the record. Everybody knows that the hand hygiene is going on. Radio frequency identification tag means you can find people and things quicker. What if there was a tool that lets you know that a fall's about to happen and you can stop it? What about medication administration, keeping up with that? And so on. You get my drift here. What about the use of dashboards so that a nurse, a busy nurse that has 8, 10 patients and the doctor comes in every few minutes, what if they can look and see, okay, this is what's happened, the status of my patients. Oh, that one needs help right there. And then between doctors and nurses is, when you go into the hospital, do you know exactly where to go? When you're with the doctor, can you video conference in with your family? And things like that. So here's tools in the inpatient setting that the patient is using to know more about what's going on with them. Just some more sort of high-level slides. We in Káiser have seen centralized health services in earlier years so that you could go one place and get everything done. And then it became computerized, connected care in the hospital. So you tie all that information together that's collected. But now we're going into the digital health area so that you can get care wherever you are, whatever you're doing. In the car, at home, while you're at your job, you can be feeding information that can be used. And of course, the foundation is the health system with all its tools. The connection point is the electronic health record. I haven't used the term HIE, Health Information Exchange. The problem is, maybe you go to the hospital here, maybe you go to the clinic over here, and they're not part of the same business. How do they share information? Or maybe you go to Bogota, but your hospital's in Medellin, and you want them to know, maybe you have some kind of episode, you want them to know your records. Well, the health information exchange is how that happens. Tom and his electronics aren't doing too well here. But. So all of that's true. What are the tools for interaction? Of course, the internet or the intranet, mobile, social, voice, video, and maybe you're getting virtual care as a result. All right, here are some specific mobile applications on smartphones and iPads and iPhones and things like that at Káiser Permanente. Some of the things are you can view your health record. I mean, I can pull up, thanks to the internet here in the auditorium, I can pull up my health record on my smartphone right now. I can make an appointment for next week electronically. right now. I can see my lab results from the test I did yesterday. I can email my doctor. I can refill my prescriptions. If I'm going into a facility, a hospital or a clinic, I can find, you know, it's like your GPS. Here you are now, and I got to get to that office 4 floors above. I can get there because the phone's going to tell me how to do it, and so on. So these are the tools we're using right now. I'll say something. Many of you know mobile apps for healthcare. What's the number? The answer is 50,000. There's 50,000 mobile apps. How many of them actually work like a device in a regulatory environment in the way that all the checks and balances are quality in there? Maybe 100. How many is my organization using? We're studying 50 of them, and we want to deploy 10 of them. So the problem is, how does it really make a difference for hypertension or heart failure or diabetes? How does it give you information you didn't already have? And the answer is, it's an evolution. We're not there yet. All right, I've been hanging around hospitals 40 years. Okay, I'll admit it, I love nurses. They're, you know, angels of mercy. But what does a nurse's day look like? And you're going to keep me on track, on time, Tatiana. They're busy. What part of that did you not understand? They're very busy. There's alarms coming depending on the acuity of the room where they are. You know, there's the alarm coming from the ventilator, from the patient monitor, from the infusion device. It's very noisy. It's very stressful. It doesn't always help them do their job and take care of patients, which is what they were trained to do. Actually, my organization and some others did a study that said 7% of the time a nurse actually is kind of with the patient, touching them, assessing them. 17% is getting those drugs right. 35% on documentation. 35% on documentation, a third of the time. Is that how you want to use your nurses? Who knows what the biggest cost in healthcare is? Doctor and nurse salaries. So if you get smarter clinical workflows for doctors and you get smarter use of nurses, then you've improved healthcare a lot. Daytime nurses spend about 30% of the time in the room, and they do this care coordination. I said it earlier, but my wife had a hard health episode a couple years ago. She didn't want to go through that without a care coordinator. That was me. All of you have done that for your family members. Care coordination, all the handoffs and all the discussions from one doctor to another, one department to another, it's a big deal. I'd like nurses caring about that more. But now, okay, it looks a little busy, all the stuff. She could be a male nurse, but in this one's a female. She's wearing all these communication devices, pagers and, you know, telecommunications devices and so forth. What if they were all in one box? And she had voice and messages and, you know, like chat, alerts, maybe looking at people face to face like FaceTime, all that integration information from the medical devices, and she was told, okay, here's where you are in your workflow for this patient, you can do the next thing. What if all that was in one box? So here's some of the things, and I'll speed up a little bit, that we're doing in Káiser. Every time you log into the electronic health record, you go from one patient room to the next, it makes you start all over again. What if we made that really easy? That's called rapid sign-on. What if we started doing this clinical decision support that I was talking about with clinical intelligence in real time? What if you could automate some of the workflow and the tasks that the nurses have to do? And what if you could do this while you're walking through your day, if you're a nurse? This is all about nurses, and it combines all these puzzle pieces that I mentioned down here. All right, back to the notion of device information. So what is the actual business reason for devices information flowing into electronic health record automatically? And, well, okay, it gives real-time patient information. It, currently, this is devices and the way it is sort of before integration. It requires, those most critical devices require the most documentation from clinicians. And because of human error, there's errors, and in my country it's worth $17 billion a year, these errors, because of manual entry of data. It says 25% of entry vital signs have one or more errors. And then every time you deliver a service and you're a hospital administrator, you want to get captured the service that you delivered accurately so you can be reimbursed for it. Well, in integration, you know, if the data from all those vital signs monitors went directly through some kind of filter, as I was talking about earlier, we call it middleware. It takes all this glut of fire hose of data and it sifts it into exactly the right information. And then it gets into that flow sheet, gets into that electronic health record in a way that the nurse and doctor can see the trended vital signs and what's happening, maybe in response to some treatment. I mean, this is actual data. Okay, it's pretty general here, but you can start to use nurses and anesthesia teams faster. Full-time equivalent, people efficiency gains. You can improve revenue capture. You can reduce the use of supplies. You can literally reduce adverse events. And you can reduce overtime. So these are things that we've done measurably in Káiser. All right, here's my case studies. This is kind of the heart. One of them is about interactive patient care in the hospital room setting. That's Health 360. Something about interacting with technology and clinicians in a smart way. Here's more about clinical decision support. And it's around two issues I mentioned. We're doing it around sepsis, which you all recognize as those infections you get into hospitals that can turn out to be deadly, or community-acquired pneumonia. Once again, infections you get in hospitals, in this case, pneumococcus, and the clinicians can tell me how to pronounce that. But what if you could see it coming and head it off before it got there? Mobile vital signs. Okay, it's nice if you have a intensive care room and you got all those patient monitors, or you have neonatal intensive care. We've all seen the pictures of the baby. It's in the middle and there's 20 devices around. 5 minutes to go. I can do that. But what about as you're carrying the patient through the hospital and all that vital signs information? How does that get in the electronic health record in a smart way? And then telehealth. So we want to be able to do care anywhere, anytime. And in this interactive patient care, it's a lot of voice, it's a lot of telecommunication, it's a lot of TIC in Spanish going on. So what Káiser did is brought a bunch of companies that can do a lot of good things together around this solution. The punchline is here at the bottom. We wanted a secure text messaging, real-time care. We wanted video teleconsult. We wanted to know sort of event management, what's going on, rapid sign-on, real-time location of where everybody was, the care team, the patient, the bed, the clinical engineers. We wanted mobile wayfinding. How do you find your way in the hospital? Interactive patient education, remote diabetic monitoring. This is a project that is ongoing right now. And I'm not going to read all this, but you want communications to take place, you want video teleconsult, real-time location awareness, and you want an interactive patient care. This is a little bit hard to see, but you get my, all right, so over here is the patient. The patient is controlling room, is controlling service to themselves, education, entertainment, dietary, pain management. Patient education has a team here. There's a two-way mobility going on in here with people with iPads and smart devices, and a home portal if they're connected to home. There's two-way video, and then there's integration of all this stuff into the electronic health record. A little bit busy, but you get the picture. This is something particularly that happens in the inpatient setting. And we're trying to go from, a noisy environment and multiple devices and so forth into more secure, controlling clinical alarms and alerts you see in the middle, then off-campus, easy communication, and then in the inpatient setting, a single device, it's quiet, all the messaging is going around is appropriately controlled in a standardized platform. All right, in the future, more of the same. The patient will generate more of their data. The video teleconsult will happen, faster. Alerts, real time, will tell you what's happening with the patient right now, what you need to do about them, and smarter ways of doing wayfinding. All right, this is as a part of that, it said chronic disease management. That was one of the sub-bullets earlier. This is a mHealth, mobile health pilot going on right now. So what does it say? Members plug in their smartphone and all their data uploads. So they're continuous monitoring. That's kind of the future is, if I have a smartphone and it's monitoring some of my vital signs, it's doing it continuously if I want it to. So that gets sent to the clinicians. They can trend it. Come on, baby. Doesn't want to come back. There it is. The clinicians can trend it ahead of time. They can get on the computer with the patient and show them how they're doing. And then there's a lot of other analysis that goes down below. So what does it say? This happened in our Colorado area. Very small population in this case, trying to see if we can do it well before we make it big. Blood sugar was just a number. Now they can, patients can visualize their blood sugar readings over time, understand when it's in the recommended range. They can change what they do every day while they're at home. So, and there's certain glucometers that have Bluetooth capability and so forth. So, clinical decision support tools. This is data being collected, basically on the left, that gives scoring to certain algorithms that say sepsis is coming, and it stops it. You can take action before it gets there. And similarly, and also some around SIRS, systemic inflammatory response syndrome, can see shock developing and take steps before it gets too far down the way. And similarly, with community credit, we're getting towards screenshots from my electronic health record. And here's some screenshots from the electronic health record that show, sepsis is about to happen, or community-acquired pneumonia is about to happen. This is what a dashboard looks like, maybe in an intensive care unit. And you can see with the visual cues, all this medical device data is feeding into this health IT tool that's shown maybe in an overhead monitor at the nurse's station in an intensive care unit. And they can see, the nurse can see quickly, and the doctor can see, this whole array of data, and tells them what to be working on for that patient. And the mobile vital signs, there was a test of that you can see. And, the big thing there is nurses spend too much time documenting because the data, and they could be using that time and energy other ways. This is some research data, about when they put the data in for these mobile devices, there's a lot of inaccuracies, as you heard me say earlier. So we did this pilot, and we got real good measures. A big thing on a mobile device is how do you know which patient it is, and how do you know which patient's electronic health record to send it to? So patient ID is a big deal. So they did a pilot, they got the cost of it, and they started saving time per patient. It worked really well. So it can be smart about how to telehealth, minimize unnecessarily emergency room visits, and so forth. There's a strategy here. I'll spare you right now. Here's sort of the path we're on. There were internal teleconsults, like maybe I'm in the operating room and I want the other surgical subspecialists to look at the data I'm looking at, but they're across campus, across city, show them the information. Or maybe it's the orthopedic injury, 30 miles from Medellin, but they want to send it to the orthopedist in Medellin, that kind of teleconsult. So we're doing video visits, and you can see an increasing number of video visits. And some of the devices used in that, you can see here, endoscopes, dermoscopes, ophthalmoscopes, and so on. We've got other data about some of our health IT tools. This is more about this national drive to get everybody on electronic health records and some of the measures around that. This was this national award. About 20 organizations in America have won this now, using the electronic health record to improve clinical care, but still have a good return on interest. We're going to do more and more mobile health in the near future. These are some of the kinds of tools. And, our future is care delivery in all environments. So.
Bueno, muchas gracias al doctor Thomas Judd por la excelente conferencia. A ustedes por haber asistido. Queríamos transmitirle un mensaje a veces de futuro, que es este nuevo actor a través de las redes, de la integración y de la inteligencia hospitalaria que se viene gestando en el mundo. Las diapositivas se les van a enviar, ustedes enviaron la inscripción, lo mismo que la filmación, que está en Renata, que es la red de Internet 2 de universidades, pero se les va a enviar un password donde ustedes acceden a ser virtual y ahí pueden bajar las diapositivas y pueden bajarla. Si quieren repetir la exposición, va a quedar ahí. Nuevamente, muchas gracias. Damos por terminado el evento. Gracias.